Hello everyone. Now I am going to show you a case. A 45 years old chronic smoker came to my OPD with a history of chronic cough from some days. Okay, and he has no history of fever and no history, and he has a history of weight loss from some days. And on examination, I had seen that he had hypertension. He was hypertensive and pressure was 160 by 98. Okay, I had given him the antihypertensive drug. And when I had auscultated the chest, I had seen some diminution of breath sound in bilateral lung, and seen that there is some bronchial breath sound in left middle zone. Okay, and then I had so it is a case of diabetic, and chronic smoking is also there. Chronic smoking is also a risk factor of diabetes and dyslipidemia. I had given him a lipid profile, and I had done him the CBG. Though he had no history of diabetes mellitus, I had done a CBG for him. So I had surprised that CBG was 449 at that time. And then I had went for a chest x-ray, and you can see that an anti-diabetic drug was also anti-diabetic medication is also given then. And you can see in the chest x-ray that there is a new clear cut pneumonia in left middle zone. Okay, so then I had given him the sputum for AAP, but he has a dry cough, so I had given mucinex, that N-acetylcysteine for N-acetylcysteine 600 BD dose for 5 days. And after that I had told him for sputum examination for the AFB and Sevina, and also Ramstein and Ehrenstein. So, and you can see that in culture sensitivity or of the sputum is also advised. So there is there I had seen that there is the rifampicin sensitive tuberculosis acid-fast bacilli was diagnosed by AB and Trunad. Okay, so the thing is this, yes, in the smoking patient and diabetic patients, especially in diabetic patients, silent TB may occur. And you can see that most of the times tuberculosis occurs in this part, in apex of the lung. But in diabetes, tuberculosis may occur silently, and tuberculosis may occur in any part of the lung. So the patient is now in anti-diabetic medication, anti-hypertensive medication, and also with anti-tubercular drug therapy. So moral of the story is that you need to screen the diabetic patient for very cautiously, and you need to check everything in diabetic patient. It may be any silent tuberculosis, any silent infection may be there, and especially in diabetic patient there is a chances of neuropathy. So you need to examine the foods and neuropathy to prevent any ulcer, because sensation is lost, so he cannot feel that there is some PR is done, and that wound infection is very common in diabetes, because blood glucose is very high and bacteria is getting food from there. So diabetic patient need to be treated very cautiously, and COPD patient need to be treated for tuberculosis routinely for once, at least once in a year. Okay, thank you.